right. Here we go. Welcome in, everyone. So glad to see you on this warm, beautiful July 1st day. We are here with another Great Lakes ROTA-R presentation regarding co-occurring substance use disorders and PTSD. This session is being hosted by our partner, UW-Madison Extension, so we thank them for providing that to us today. I'm going to go ahead and go through a couple of housekeeping items. If you've been with us before, you know what it's all about. So just hold tight and we'll get right into our presentation. I just want to acknowledge that Great Lakes ROTA-R is a SAMHSA-funded grant project, and we cover HHS Region 5 and the states you see on the slide. You can also see our website listed there. We'll be putting that up into the chat later at the end of the session. But just a brief look at our website, you can get access to virtual education hosted by us and by our partners, sign up for our newsletter, and request technical assistance, as well as access a rather large e-library of resources. Speaking of our newsletter, we encourage you to sign up because you can find out about training upcoming. We'll tell you a little bit more about things we have on the calendar for the rest of July after Dr. Norman's session today. But we encourage you to check it out for yourself, get signed up, and get that immediate notice of things coming up. As we get ready to start our session, I just want to prepare us all to listen and engage in the session content. Just take a moment to promote that use of affirming person-first language when we're talking about behavioral health and behavioral health disorders. That will help us create a great virtual learning community in which people feel comfortable to participate, share their experience in a non-stigmatizing, recovery-oriented way. So with that, I invite you to actively participate from whatever space you're joining us today and welcome you formally into the Great Lakes ROTA-R virtual learning community. I would like to now introduce our presenter for today, Dr. Sonia Norman. Dr. Norman is the director of the PTSD consultation program for the National Center for PTSD. She is also professor of psychiatry at the University of California in San Diego at the School of Medicine, a clinical psychologist and researcher in the treatment of PTSD and addictions, as well as novel treatments to address trauma-related guilt, shame, and moral injury. I'm going to pause there and I'm going to turn the presentation over to Dr. Norman. Let's welcome her in.
Hi, everyone. Let me go ahead and pull my slides up. There we go. Can you see that? Okay, so I'm very much looking forward to chatting with you about PTSD and co-occurring substance use disorders today. Please go ahead and put questions in the chat, and I'll also leave time for questions at the end. But I'm hoping to just share with you some of what we know about PTSD and substance use disorder and how they co-occur. I'll go a little bit more into PTSD since I know you all are out there working with substance use disorders every day. I'll talk about what we know about treating the two when they co-occur through a research lens, but then spend a good part of the talk just talking about what we've learned over the years as clinicians in terms of engaging and helping this kind of tough population succeed in treatment, and share some resources with you that might be helpful in your work. So let's start with what is PTSD and kind of go through that a bit. So the one thing that I always find interesting is that PTSD and substance use disorders, which co-occur so often, have something in common that no other psychiatric disorders have, which is that you need an external event to occur. So you could have all the genetic predisposition to develop PTSD, but if you never experience a traumatic event, you won't. And someone could have all the genetic predisposition to develop an addiction, but if they never encounter a substance, they won't, right? So, so with PTSD, someone does have to experience a life-threatening traumatic event, and the DSM is pretty clear on what that is, although it changes a little bit in each edition as we learn more about kind of the scope of events that can occur and how people can respond to them. So in common English, I might say, my car broke down, it was so traumatic. I got fired, it was so traumatic. My partner broke up with me, it was so traumatic. All true. But for the purpose of the diagnosis, we're really looking for life-threatening traumas or sexual abuse, sexual assault, in order to meet that criteria for to be diagnostic for PTSD. So certainly, as we've all seen, breakups, job loss, those kinds of things can lead people, can trigger depressive episodes, anxiety, other things that we can certainly treat. But for it to be a PTSD diagnosis, it needs to be that life-threatening trauma. And someone needs to have experienced it directly or witnessed directly someone else experiencing it or learning about the violent or unexpected death of someone. So this was a clarification in the last update of the diagnostic manual, the DSM, because before it just said the death of a loved one. So people were in surveys saying, oh yes, my 95-year-old grandfather died peacefully in his sleep. So now we clarify that it's a violent death or an unexpected death. You don't have to have seen it, but if it's someone close to you, it can count as a traumatic event. And experiencing repeated or extreme exposure to aversive details of traumatic events. That also was new between the DSM 4th edition and the 5th edition, because we were seeing that people who weren't necessarily in danger, but had jobs such as, police officers who have to watch footage of child sexual abuse to catch predators, and they watch that footage day in, day out. They could be developing PTSD. So this has to happen in the scope of someone's work. It's not just if I choose in my own time to watch violent YouTube videos, that wouldn't count as a criterion A to develop PTSD, but if someone as part of their work does, it can. More of us will experience a traumatic event in our lifetime than not. So these are quite common, especially if you think about things like accidents, being the victim of a crime, of a natural disaster, things where someone thinks I might die or witness someone else getting hurt. But the good news is that most people recover after the traumatic event. So right after, someone might have a hard time not thinking about it, have trouble sleeping, feel very on edge, have some of the symptoms that can go on to become symptoms of PTSD. But most people recover naturally over the first month or 2 or 3. And it's the people who kind of continue to maintain that high threshold of symptoms that can be diagnosed a month later. And in fact, we don't diagnose people in the first month because it is so common to have symptoms immediately after the traumatic event. But about 6 to 7% of people in their lifetime will have had PTSD. And it's actually not that much higher for veterans either. It's something like 7 to 8% higher among combat veterans and those seeking services in the VA. So talked about how common it is to experience a trauma. And then if someone comes to you and you're trying to assess what's going on, is this depression, anxiety, PTSD, they had the traumatic event. And then to diagnose PTSD, we also want to see that they have some specific symptoms linked to the trauma. So they need to have at least one re-experiencing symptom, which is that they have a hard time not thinking about it. They get emotionally upset when they do think about the trauma, or they get very physically worked up. It might be sweating, heart rate, panicky feelings, or they have nightmares, or they might even have flashbacks where they think it's happened, where they truly believe the trauma is happening again. And then they need to have at least one avoidance symptom, which is either trying not to think or have the feelings that are associated with the trauma, or actually avoiding activities, people. So you'll hear people with PTSD say, oh no, I can't do crowds. I won't go to concerts anymore. I won't go to, the big box store when it's crowded. I won't have intimate conversations. Those are all avoidance of kind of people or places or situations. Negative alterations in cognitions and mood. People will feel sometimes guilt or anger, shame, blame themselves, blame others, have a hard time feeling positive emotions. So they need at least 2 of those. And hyperarousal are the really classic ones, the startle, fireworks go off, which is apropos for this week, and they jump and, more than anyone else in the room, or they'll only sit in a restaurant in the corner where they could look out and scan and for danger the whole time, things like that. Trouble concentrating, trouble sleeping. So they need at least 2 of those symptoms. So if they meet all of those criteria and they have distress and impairment, you can diagnose PTSD. Another interesting factoid about PTSD is that it's one of the least common diagnoses in the diagnostic manual to occur on its own. So 80% of the time, at least, that people have PTSD, they'll also meet criteria for another disorder, often depression or an anxiety disorder, a substance use disorder. They might have impacts from a traumatic brain injury, things like that. And sometimes people in Europe, especially, they differentiate PTSD from complex PTSD. But honestly, those of us who work anywhere in the world with PTSD will tell you that all PTSD is pretty complex. It often comes along with, trouble in relationships, trouble functioning, legal problems, health problems, substance use. We also see pain and traumatic brain injury and insomnia. So substance use disorder is one of the most common comorbidities. In clinical samples, whether we're go into a PTSD treatment program and look at how many people would meet criteria for a substance use disorder, or we go into a substance use treatment setting and assess how many people would meet criteria for PTSD, it's often upwards of half. The comorbidity is very common. And as I mentioned, we see worse treatment outcomes, more medical and psychiatric diagnoses in people who have both. Some of the other things I haven't mentioned yet is higher risk for suicide, higher risk for future trauma, and higher risk for aggression or violence when people have both. So how do the two influence each other? One of the things we've seen by studying, kind of treatment over time and just people over time who have both is that if patients with PTSD will benefit less from substance use treatment than patients without PTSD. PTSD symptoms people with PTSD can have more relapse and more subsequent substance use. And if PTSD is treated or it remits in whatever way, it's associated with better substance use outcomes. But if substance use is treated on its own, it's not necessarily associated with better PTSD outcomes. So this is kind of a quick summary of many different researchers' work and from primarily US, but many parts of the world. We see this over and over. And this actually really flies in the face of what we've done traditionally, which is try to treat the substance use disorder first. So flag that. I'll come back to it in a minute. But we have, the good news is that we have really good treatments for both PTSD and substance use disorders. As you know, that doesn't mean every person benefits or benefits on their first try. It doesn't mean that everyone achieves full permanent recovery, but it means we can help people feel a lot better. We can help people function a lot better, meet their work goals, their relationship goals, feel better about their lives, and in some cases have full long-term recovery. So there's several different documents, including work put out by SAMHSA that look at what are the best treatments that are most likely to lead to recovery. I'll talk with you a little bit about the VA DoD guidelines, and we have guidelines for PTSD that were updated in 2023, and we have updates for substance use disorder that were updated in 2022. I'll tell you that sometimes VA DoD leads people to think that these only look at research or work that has been done with veterans or active duty military, and that's not true. While these are conducted by teams put together by the VA and Department of Defense, these look at all the studies with any population that meet the criteria. So in the PTSD guidelines, there's 3 therapies that meet the highest bar for kind of helping the most people recover with the greatest symptom reduction, kind of the most effective. And these have also been studied with the most different populations by people who aren't the people who develop them, which even with the best intentions can lead to more bias, with the most comorbidities. And so for PTSD, these are prolonged exposure therapy, cognitive processing therapy, and EMDR. We often find that EMDR is the one people have heard of the most. It's kind of the most disseminated um, around, the communities and around the world. But these all work really well. They're all time limited, meaning they're not like, come forever kind of supportive therapies. They're all about 12 sessions, give or take a few. Some people are done sooner. Some people need a few more sessions. Traditionally, we used to do them once a week, but now we have a good deal of research showing that you can do them in a massed format, meaning someone could come several times a week or every day and be done in like 2 weeks, and they work just as well. And a nice byproduct is actually dropout is much lower when people do them in a massed format. Of course, not everyone can because of work or childcare responsibilities or other life things, but for those who can, it's a really great format, and some people prefer it. To give you kind of a one-sentence summary of each of these, with prolonged exposure, the idea is that not everyone develops PTSD after trauma, and those who do might be more likely to push away and avoid thinking about what happened, the emotions of what happened, any fear, grief, guilt that they might feel. They're not really processing it, and this leads to more and more avoidance, even in safe situations. So PE counteracts that by having people retell the memory to the therapist and even actually record that and listen to it to kind of take that power away from the memory. The event was dangerous. Memories can be upsetting, but they're not intrinsically dangerous. And when someone tells the story over and over, they actually get kind of bored of it. They take control of it. It no longer has that power over them. And it is a very powerful tool for recovery. And at the same time, that we call imaginal exposure. They're also doing in vivo exposure, which is that they make a list with the therapist of things they've been avoiding, the people, the places, the smells, the activities, and they rate how upsetting it is to even think about doing it, and they start doing some of those things. And they're things that are objectively safe that other people in their town are doing, and they stay in the situation long enough for that anxiety to run its course, and they realize, oh, I can handle this, I can do this, and they kind of reclaim a lot of their lives, and they're functioning that way. In cognitive processing therapy, the idea is that those who develop PTSD might take on more extreme views after the trauma in terms of feeling like, wow, I'm not competent to keep myself safe. Wow, the world is extremely dangerous. And so the therapy goes through a series of progressive exercises to help people challenge those beliefs and get back to a place that's more reasonable for their lives, for their settings, so that these extreme thoughts aren't driving their behavior, their feelings. And in EMDR, there's kind of a reconnection between the thoughts and the body because it's thought that a lot of trauma is stored in the body. So people kind of think about the trauma, and they think about the trauma story while they are also activating their body in some way, whether through tapping or um, eye movements. And over time, the memory becomes less upsetting. So these therapies work really well. This is a study that followed people for 5 to 10 years after. It used a diagnostic measure of PTSD, where over 40 is considered probably having PTSD. So at the start of the treatment, people had a 70. By the end of treatment, they were right around 40, meaning some were really recovered, some were still symptomatic, because this is average. 9 months later, they maintained those gains, and 5 to 10 years later, they were doing even better. So this is really powerful because, for example, when people take medicine like antidepressants that work for PTSD, any medication, we kind of expect the meds to work while you're on them. We don't expect them to have this kind of long-term recovery. So this is really very powerful. And we see that more than half of people who do these therapies do, in fact, lose their diagnosis and don't meet criteria for PTSD anymore. It's a little bit lower for medication and very low for people who get no treatment at all. There are medications that are effective to treat PTSD. These are primarily, like I mentioned, antidepressants. They're not quite as effective as the therapies I described to you, but sometimes people do both meds and therapy. That's very common, and some people really just prefer the meds, and that is an effective treatment. On the substance use side, the VA DoD guidelines recommendations are much more complicated because it's not just which treatment, it's also which substance, right? So there's things that have been tested for alcohol use disorder that we don't yet know about opioids or stimulants. So it's a much more complicated grid. And then there's, kind of on their own treatments and adjunctive treatments with medication. So it just becomes kind of more complicated. But the good news is, as you know, we have effective treatments. These are some more that I'll let you read. So going back now to that history, when I first started working in the field, I started at the VA in a PTSD program, and this was around like 2007, 2008, and we had it through the electronic medical record. You could place a consult for a veteran to go to the PTSD treatment program, and the clinician who was filling out that consult, it was like a little template, and they had to check some boxes and answer a couple of questions. And one of the questions was, does the person have a substance use disorder? Are they still using? Have they been abstinent for 6 months? And if the answers were yes, then we literally wouldn't take that consult. We would say, oh, well, the person needs to work on their substance use recovery more first. They're not ready for PTSD treatment. And that was very much the belief at the time, and it's still often the belief among clinicians, among people with these disorders. But as I mentioned a few minutes ago, the research actually really doesn't support that. And in fact, the research shows that patients with PTSD benefit less from substance use treatments than patients without, that PTSD symptoms predict greater substance use. It's a significant predictor of relapse. And that if we do treat the PTSD and PTSD gets better, people actually do better in their substance use treatment too. So given this, the VA DoD PTSD guideline actually says very strongly that we don't want people who have co-occurring substance use disorder to be excluded from recommended PTSD treatments like prolonged exposure, cognitive processing therapy, and EMDR. And the substance use guidelines similarly says that we should assess for comorbidities, including PTSD, and get people the best treatments available for those. Often when people get treatment for both, what it means is that they're kind of separately getting the treatment. So they might be coming to an outpatient substance use treatment program and going to some programming there, have their case manager be doing some groups, and then they have a therapist with whom they're doing their PTSD treatment. And that's great. And in the ideal world, those clinicians are talking to each other and coordinating the patient's care and seeing how the person's doing across the different treatments. But there is actually also an integrated protocol with evidence. So Sudi Back is the first author of that, and it's a very long title, Concurrent Treatment of, let me see, I have to move this, PTSD and Substance Use Disorder using Prolonged Exposure. But luckily, all those words make a great acronym, which is COPE. And so COPE is 12 individual weekly sessions. They're 90 minutes, and they combine two evidence-based protocols, prolonged exposure for PTSD and cognitive behavioral therapy for substance use disorder. And so the protocol helps clients understand the relationship between the two disorders and uses PE to prolonged exposure to help with PTSD symptoms and cognitive behavioral therapy to help with substance use symptoms. And each session really covers both. So for example, in the third session of prolonged exposure is when I would introduce that hierarchy where we make a list of all the things the person has been avoiding and start having the person go out and do some of those things, assuming they're considered safe in their community. But also we'll spend part of the session on managing cravings, cognitive behavioral skills for managing cravings. So in every session, there's kind of a little bit of both. I won't share too much, kind of go down rabbit holes on too many research studies, but I wanted to highlight a couple that my team has run that I think really bring home this point of not shying away from the trauma-focused treatments, like where we do have people process their traumatic event, like prolonged exposure. Um, and so one of the studies that I've led compared COPE, this protocol I just described to you, to seeking safety. And my guess is many of you have heard of seeking safety. It's a present-centered protocol, meaning that while it's meant for people with both PTSD and substance use disorder, you don't really talk about the traumatic event. You don't process the emotions or the memories in any way. You really work on sort of coping in the present, improving relationships, safe behaviors, self-care, those kinds of things. And so we were very interested because the field was moving toward this place of saying, yes, we should treat both, but people were much more comfortable with a protocol like seeking safety and still had a lot of concerns about asking people who were actively in recovery or even using harm reduction, still using substances, to process their trauma, to talk about the memory, to do things they've been avoiding. There were still a lot of beliefs that that might make them worse or that they couldn't handle it. So we decided to do a direct comparison of these two treatments. The results were published in JAMA Psychiatry in 2019. And we randomized 119 people, veterans. This was conducted at a VA, and all of them had alcohol use disorder. Many had other substance use disorders, and they all had PTSD. And one of the things we sometimes hear when we present research is, that's great, but you found the perfect research patient. We see the real world patients. Ours are complicated and messy and homeless and on multiple substances and have had a lifetime of trauma. So this is kind of a myth because I couldn't have found 119 of those perfect quote unquote research patients because they're not out there. The people that we recruit from are the same ones that you're seeing. And in fact, we were very integrated into our VA's substance use treatment program and recruiting from there and going to the team meetings, really functioning as part of the team to make sure that the patients were getting really good coordinated care. But what we found is on average, people had over 8 trauma types. So not traumas, but trauma types, meaning that they might have been in a disaster and might have been assaulted and, other things. And that many had additional substance use disorders also, in addition to the alcohol use disorder. And what we found is that both therapies, whether people got the integrated prolonged exposure therapy or seeking safety, they had pretty good outcomes for alcohol use, that they reduced quite a bit, and that lasted when we saw them at post-treatment and 3 months later and 6 months later. But the group that got the prolonged exposure integrated protocol did better in their PTSD. They had greater symptom reduction at post-treatment, and they maintained that 3 months later and 6 months later. So for PTSD, we got a bigger bang for our buck for having people do the exposure. We did not find that people relapsed more. We did not find that people had more worsening of symptoms. Jessica Tripp, who was an investigator working with us, did a paper on that and saw that we did not have differential kind of worsening or relapse or other outcomes. We did have higher dropout in the prolonged exposure condition, so that's something we've given a lot of thought to. So in part, one of the things we've been very interested in is, what do we do about the dropout? With any treatments, as you know, this population, substance use folks drop out, come back, drop out pretty frequently, or it's not uncommon. And then with PTSD, we also have this prominent symptom of avoidance. The last thing people want to be doing is actually going to, therapy. And so we have a lot of dropout too. And so one of our theories was that if we looked at higher levels of care, that we might see less dropout. So there's been a lot of studies of treating PTSD and substance use disorder. To date, they've been almost exclusively weekly outpatient treatments. And yet what we know is that with substance use, people often are in intensive outpatient, where they're doing something multiple times a week, or sometimes even residential. And so we looked in a VA residential substance use treatment program. Some people, this is a program where 9 beds are designated for people who have who also have PTSD in addition to a substance use disorder. And generally they get more kind of at that time, they got more of a coping skills kind of treatment. And we said, what happened if you bring in PE and you do it multiple times a week? And so what we found is, none of them used over treatment in residential because they weren't allowed to. So we looked at the PTSD and depression outcomes. And what we saw was that PTSD scores were much lower among the ones that got the prolonged exposure therapy, as opposed to, the treatment as usual. And what we were really interested in is what happens after discharge, because when they're in the residential program, all the chaos of their lives is quieted down. They have a routine, they have meals, they're safe, they have, support. But what happens when they go back out into the world? So we looked from post to 3-month follow-up. And what we found is that the PTSD symptoms continue to trend down for the people who got prolonged exposure, while they trended up for the people who didn't, who got treatment as usual. And for depression, people looked kind of the same at discharge, but the depression symptoms continued to trend down for those who got prolonged exposure and trended up for those who got treatment as usual. So that was really important information for us. And we now have 2 different grants, one in the VA and one in a community treatment program in Florida, where we're looking at people who are in intensive outpatient or residential substance use treatment and seeing what happens when we bring prolonged exposure into that setting. Because unlike the myths that they would get worse, and this is, the people who need residential or intensive treatment are kind of the most severe, right? And in fact, what we found is that when they had that extra level of support, they really were more likely to succeed in the treatment. We actually didn't have any dropout, which is very unusual, and that they, it kind of gave them the buffering, the support to do the treatment and not drop out and not, and succeed in it. And we interviewed all the folks at the end, and we were told things like, I've always known I needed this, but everyone kept telling me I wasn't ready, right? So they were actually happy to have had the opportunity. And there were probably some who said no, so maybe those who didn't want the opportunity, but there were plenty out there who did want it, who did want their PTSD treated and were willing to talk about their trauma. So in terms of what we learned for that is that patients with PTSD and substance use disorder, as the field is kind of moving to, should really be offered treatment for both. And I guess the question is, what does that mean for, a practice and people working in these settings? And how do you know when to offer treatment? How do you bring it up? So, the first part, of course, would be screening, diagnosing. But then once you've established that someone does have both, one of the tools that we found is really effective is shared decision-making, where, the clinician and the patient use a collaborative approach. So talk about, this is substance use disorder, this is PTSD, these are the recommendations for treating both, these are the options we have. We could treat them, at the same time, but with separate clinicians. We could try COPE, which is an integrated protocol. Some of the things we might look for is the person either abstinent or willing to cut down? In our studies and in our clinical work, we're able to use a harm reduction model as long as it's outpatient. And so we do have lots of people who are still using, but actively working on cutting down or quitting. Are they willing to not come to sessions just having used? Or if there's homework assignments in the therapy they're doing, are they willing not to use right before they do those, or even right after? Because we want them to learn, oh, I can go to Target and I can handle it. We don't want them to learn, I can go to Target, I can white knuckle it, and then I can, use right after I leave. That kind of sabotages the therapy. So are they willing to do their best? And they might slip occasionally, but are they willing to do their best not to use in a way that would disrupt treatment? Do they want treatment? And honestly, I personally have found this to be the greatest predictor. I know I've been led teams and been on clinical teams where we'll kind of sit in a room and discuss a client and say things like, well, he's homeless, so this probably isn't a good time for him. But then I've had people come in and say, yes, I'm living in my car, but here's how I can listen to the sessions with them on my phone after I record them. Here's how I can, get the homework done. And sometimes we find that if they really want to do this and they're willing to overcome obstacles and be creative, it's that treating their PTSD that actually allows them to be successful in getting long-term housing or, getting a long-term job, things like that. And we want to see what supports are in place, and are they sort of set up to succeed, and can we help them get the proper supports to succeed? If they're amenable to getting treatment, then we want to think about with them, does integrated or concurrent treatment make sense? If they're already coming to an intensive substance use treatment program 3 times a week, then I don't think you need to do COPE because they're already getting the substance use treatment. Just add the PTSD treatment. If they're not getting either and they're really busy and the only way they can do it is if they can integrate the 2 into 1 appointment, then COPE is a great option. It's really helpful to work collaboratively with the patient on the goal. I'm sure that, that the way you think about this and the people coming to you think about this isn't so much, and I want to see PTSD symptoms go down by 10 points on the self-report measure. It's, I want to keep a job. I want to, get my PTSD enough in check that I could go on a plane and meet my grandchild and be able to hug my grandchild. And, it's more about recovery and functioning and meaning and what would really, show tell the person that, wow, I've really recovered. I've really achieved what I want to achieve. Consider psychotherapy or medication or both, and other things like pain and other things that you need to consider to treat them successfully. So shared decision making is kind of a specific process to do this, where the provider and the patient work together to make healthcare decisions that really consider the patient's preferences and abilities and what matters to them. It's kind of in the middle, where paternalism is where I, as the clinician, say, I am the expert and I tell unto you, client, what is best for you. Versus there's, sometimes we have people who come in and say, hey, I did an internet search and I saw this thing where I can take psychedelics for 10 days and be cured. You on board with that? And if you say yes, that would be letting the patient guide the treatment completely in the absence of the evidence and safety and other things, right? Which we don't usually do. So shared decision making is kind of meeting in the middle of sharing a lot of information about what works and what we know, and then kind of using a collaborative process to decide on what makes sense for the patient. And it's great to use shared decision making, especially when there's multiple good treatment options. Often patients are then more engaged in the treatment because they feel like they had a stake in what works. And ethically, it makes a lot of sense as well. So some of the choices we might make are, do we want to do integrated like COPE, or let's say you have someone in your clinic trained in EMDR or not COPE. You could also always integrate EMDR with some substance use treatment for that integrated experience. Or we could do, concurrent treatment, which might make sense for someone who's already receiving a high level of substance use care. So in terms of then, it would be nice if we made those treatment decisions with our clients, and then we started treatment, and then they went through treatment, and then we finished treatment, and then they were better. And sometimes it happens just like that, but of course, often there's a lot of life that happens in between, and the patients have, crises and other things that draw their attention. They relapse, other things get in the way, they drop out. So we want to be prepared for that as well, because that's, again, the norm, not the exception. So here are some strategies for kind of as you're going through therapy with comorbid patients that have been found to be helpful. So, we talked about kind of helping the person identify what matters to them, their motivation, their, what would make them feel like they've really met their goals. We don't want to just do that on the front end because it's easy for them to kind of drift further from having those front and center over the course of therapy. So we really want to use our motivational skills and continue to help them kind of keep what's meaningful to them, what matters, why they're doing this front and center throughout treatment. Sometimes these patients will show up, of course, intoxicated, and you want to know your local site procedures for helping them get home safely. You want to decide if you're, um, you know, doing, are they able to do a session and engage today, or would it be better to reschedule? Um, Help them connect with other substance use resources or other resources for traumatized folks, for veterans, for sexual assault survivors, whatever they might be, if that's something that they're interested in. And really help instill hope because often these patients will feel like they've tried everything or nothing will work for them. And so knowing that these treatments do work can be really helpful. And I know I'm sharing a lot of data with you today that suggests that. In my own experience, the data is helpful, but when clinicians really turn the corners when they've been doing this work and see how much treating both with evidence-based treatments can really help people recover, and then it comes from the heart in a way that just, knowing what the studies show doesn't necessarily. But if what you have for now is the studies, they are pretty promising in terms of that we can help these folks. We do this first bullet is probably more for a PTSD crowd where PTSD clinicians often aren't used to asking about use in the past week, or is it worse? Is it better? What have you used? How much? But that's really important when you're treating the comorbidity. So especially when we're working with PTSD clinicians, we try to get them comfortable with asking those questions. Um, this is a population that truly does have a lot of crises and psychosocial stressors. So they're breaking up, they're moving out, they're losing their housing, they're losing a job, they're having a fight with someone. All of that can derail a session. Sometimes it's just because it's truly a function of their lives. Sometimes it's also because people with PTSD are really good at avoidance, and bringing a crisis into session is a really great way to avoid the hard work of processing the trauma. So we have strategies for acknowledging the crisis, for kind of triaging it in your own mind, for giving it, acknowledging it, giving it a little time, sometimes at the end of session, but letting the person know, wow, that's big. Can we talk about that at the end of session? But we do want to treat your PTSD. So overall, these kinds of things are easier for you to handle going forward. Sometimes the crisis really does need to be a showstopper, so kind of thinking about when that is. But it's very easy to go through a course of therapy with these folks, and the vast majority of the sessions become crisis management. And so we really want to be mindful not to let that happen, because then they'll never deal with the underlying issues. For therapists who are newer to this kind of work, sometimes a lapse or a relapse can feel kind of personal. I'm failing, or they don't, they're not working well with me. So to normalize that as part of the recovery process for these patients. And not everyone's goal is abstinence. So if you're in a setting that, allows for harm reduction or moderation, that can be a great start. We've often found in our research that initially people are only willing to set a harm reduction goal, but as they gain some confidence and see the benefits of it, then they're willing to move toward abstinence. We've also seen where someone comes in and says, oh yeah, I need to quit alcohol, but no, my marijuana use is very helpful. I don't want to work on that. But once they've worked a bit on their alcohol, they're willing to work on their marijuana use. So kind of meet them where they are, and keep revisiting the goals, because often we can help them shift those goals over time. We have the National Center for PTSD has a treatment decision aid that's on our website. Everything I tell you about National Center is a federal, tax-funded agency. Everything is free. Everything is there for you to use. The decision aid we actually just updated with some cool new videos and resources, but it's a great interactive resource to help folks learn about treatments and compare this kind of treatment for PTSD to this kind of treatment. Sometimes patients will do this on their own time. It's also a really nice tool to use together in session with shared decision making. And we encourage you to consider the full continuum of care available wherever you are. In VA, this is a VA kind of slide where we have everything from primary care to general mental health to specialty PTSD and substance use treatment, outpatient to residential, and then inpatient for people who need acute hospitalization. But often, someone might only be willing to be seen in primary care, or we realize someone isn't doing well outpatient and they really need that structure of residential. So not, wherever you work, not all the levels might be different, but to know your resources and know what might be available for any given patient can be really helpful. And then we also really encourage measurement, initially to establish the diagnoses, to establish severity, but all throughout care, we give self-report PTSD symptom measures, at least every other session, sometimes every session. So we want to see if someone's getting better, what if they're getting stuck, what do we need to explore, why is that happening? Might they be getting worse? We certainly want to know that. And then to sort of help people see the progress they made at the end. It's not the only marker, but it's certainly one great marker to see. We'll sometimes do like a graph and show people your symptoms started here, and the last week you're telling us they're here. That's huge. So, we have diagnostic interviews that can be quite lengthy that some settings will give, but we also have self-report measures that are much shorter. We have screening measures that take just a minute. So it kind of depends on where you're working and what makes sense. And we can measure direct symptoms, but also sometimes things like quality of life are really important, meeting goals, identify measures that make sense with the person's goals, and really use the data in therapy. And we have, in terms of PTSD measures, again, all the measures available for download on the National Center for PTSD website for free. So we have the PTSD checklist, which just asks about every single symptom, and you can really measure change over time on a scale. We have screening measures and diagnostic measures. And then we would just continue to use motivational strategies, continue to use measurement to inform, what we know and what questions we need to ask the patient, because sometimes what they're saying on the measures doesn't quite match what they're saying in the sessions. And we can learn a lot by reconciling that and continue to assess how they're doing toward their goals and their progress. For a while, many of us were doing primarily virtual treatment, but many of us are now living in a world where we're doing maybe still more virtual treatment than we were before the pandemic. And one of the questions we often get is, well, how does this apply to when we're doing, therapy with someone who has trauma, who might have suicide risk, to someone who's using. And one of the concerns we hear is, if someone's coming into session and they're not walking straight and they're kind of looking, their eyes aren't focused, and there's a lot of visual cues that show us that they might have used and they might not be in a good place for therapy that day. When they come on a screen and they're already seated, and we just see them that way, we lose a lot of that. So that is true, but there are also cues we can use on screen as well. So, so like eye contact and slurring and movements and, how they're responding to questions and things like that can be used. We'll generally set some guidelines because people might be more relaxed at home around, just like if you were in my office, no smoking, no vaping. Sometimes people are always in a different place and you have safety concerns. So we try to ask them at the beginning of session where they are. If they're not even sure because they're in their car, we can have them, send us a location or look at Google Maps and tell us what Google Maps says, share it with us on the screen. Sometimes people have Wi-Fi issues. So we've had people drive outside of a Starbucks or a library somewhere with free Wi-Fi and kind of use it from their car so they still have the privacy. We'll help them brainstorm if they have, a small apartment and a big family, what might they do to have the privacy to do therapy? So some of the big decision points, again, with the comorbid population when you're in therapy is, when do we deviate and when do we continue on with the PTSD treatment? And so one of the clear ones is, of course, if someone is under the influence, maybe it's cannabis, maybe it's alcohol, maybe they drank the night before, but you could tell they're still really not okay. Maybe it's, um, use of prescription medications not as prescribed. So, some of the things we look for would be, bloodshot, glassy eyes, watery eyes, looking more disheveled than usual, inability to maintain train of thought or repeating oneself or expressing difficulty with memory, drowsy, falling asleep, different appearance or mannerisms than we're used to seeing with them. And maybe they're having more trouble understanding what you're saying. So those are all signs that we could tell over video, but also in person, in addition to the ones that we might have walking them from the waiting room to our office and that kind of thing. Some other reason, so that might be a reason to deviate for the day. If you're seeing, sorry, let me go back. If you're seeing some of these signs, you might say, okay, you know what? Can we try again at our next appointment? I don't think this is going to work today. I could tell you're struggling to kind of stay focused on the session. I don't want to, kind of waste the time, make you feel like it's not working when really it's just that it's hard for you to engage today. Make sure they can get home safely if they need to, and reschedule for another day. So this wouldn't be stopping the therapy long term. It would just be today's not the day. When might we say, let's stop this therapy long term? Sometimes we do feel like someone's just not able to do it in outpatient. They're not showing up, they're losing their materials, they're forgetting, they're not doing the homework, and they really want to do it, but they just need more supports. They need more structure in place. And so we might consider a higher level of care. If they are having an emergency, certainly we've had people who've had, deaths in the family or some major disaster that really disrupts their ability to do the therapy. And we might consider taking a break and restarting at another time in the near future. But, again, sometimes those crises can be handled more in session, more, more without derailing the whole therapy. And this can be collaborative too, right? Because you never want the person to feel like you're dismissing their major crises, but you might want to say, can we integrate the, dealing with what's going on now into the session we were planning today? Can we spend some time with it on the end? Because I really believe that helping you with your PTSD long term will make these kinds of things easier for you to deal with when they come up, when life throws them at you. So again, use a collaborative, kind of make sure the person is on board with continuing with the PTSD treatment. If you do decide to deviate, here's just some suggested language. I'll give you a minute to read it. But sometimes clinicians, find it helpful to see how others might address these kinds of points. And I'm happy to share these slides after too, so you can have this. And so, if you do feel like it's important to deviate for a session, we can normalize that the recovery process isn't linear, because it isn't. If someone came in using when they usually don't, or reports that they've been using a lot more, we want to understand, what is the function of that use? Is it to manage symptoms that feel worse? Is it avoidance? Is it that they don't feel support? How does this fit with the client's goal? And here's another suggested kind of: you reported drinking a lot last night. Seems like you aren't able to concentrate today in session. I really want to provide you the best care, but that also requires you being able to engage in the material in session today. Why don't you tell me the reasons for drinking last night? So you can explore that a little bit and kind of do an off-protocol session. In extreme circumstances, it may be determined that the client should not continue in the therapy. This normally would be if the client was not able to attend sessions without being under the influence. So we might use shared decision-making in that case. And what we want to do is just continue to instill hope and let the person know they can return, they can try again. normalize that even though this may not be the right time, this doesn't mean the client can't come back for care in the future. And we can even set a plan for checking in about trying again. When someone is done with therapy, if you definitely want to celebrate that. Termination can be hard for both the therapist and the client, but the nice thing with these protocols is from the very start, it's clear that it's a time-limited protocol, so you're kind of checking in on that all along the way. And substance use treatment often takes much longer, so even though someone might be finished with the PTSD portion of their treatment, they're likely continuing in their substance use treatment, and they certainly can check in with you as needed. But we do want to think of this as a recovery-oriented treatment, an episode of care where someone, can come back if they need it, but there isn't an assumption that they need treatment for their PTSD continuously and forever, because that's not true. So let me share some resources with you that are available through the National Center for PTSD website that you can use anytime. So we talked about assessments. So there's, as I mentioned, you can download screening instruments, you can download self-report instruments and the longer interviews. There's trainings on how to use them. There's instructions for how to score them. These are live links. So again, you're welcome to these slides, but also you can just Google National Center for PTSD, PTSD measurement, or PTSD screening, and these will come up. For the interview, the CAPS-5 is considered the gold standard interview for diagnosing PTSD, or the gold standard way to diagnose PTSD, period. If it's something you want to learn, the National Center for PTSD website actually has these very interactive courses where you have kind of a virtual patient who will answer your questions and give you feedback, and the program will give you feedback, and you might want to ask the question a little differently to get the answer that you are looking for. So there's 3 or 4 of these that are each kind of progressively. You do the interview more independently, and there's some new ones in the works that integrate AI more. They're pretty cool. And then if you are interested in continuing education units, there's also some courses you can take for free on assessment, and some courses on PTSD and substance use comorbidity for CEUs, and more resources on shared decision making. For COPE, there is a published manual. It was published in 2015, and a patient workbook. And I do also know that Dr. Sudiback has a kind of 2.0 in the works that should be published soon. And there's some lectures that we've had in our National Center for PTSD lecture series on COPE. And one very exciting thing is the team has been working on a training in COPE called COPE Web. So it'll all be online and all virtual. And that is being alpha tested right now. So I think within the next year, it might be possible to take that also for free online. If you're interested in just staying up to date on what's new in PTSD, the National Center for PTSD has several different resources that you can subscribe to that would just get delivered to your inbox. Some are more heavily on a research topic. Some are just like what's new this month for clinicians. Some are what's new this month for consumers or, clients. So kind of just depending on what you're looking for. I get all 3. Lots of people do. The assessments we've discussed already. And we have a PTSD consultation program. This is more geared because it's the National Center for PTSD is within the VA. It is more geared to clinicians who are treating veterans, but we're available to answer questions about treating people with PTSD, including also with comorbid substance use disorder. And you actually get a human to email with or meet with to talk through your question. So those are all resources for clinicians. The decision aid, as I mentioned, can be used directly by clients or can be used together in session with the clinician also. About Face is a very rich series of videos of people with PTSD who talk about what that was like for them and talk about what treatment was like for them and how they're doing now. It does interview veterans, but their stories are so diverse, and many of their stories are about trauma in civilian life and recovery in civilian life. So they're pretty broadly applicable. And there's just such a wonderfully diverse set of people who are interviewed for the site. So someone can really find someone they can relate to and hear their story and hopefully be inspired. There's also animated videos, which are just 2-3 minutes and really kind of cover a lot of information in a very accessible way on different treatments for PTSD and why have an evidence-based treatment. And these are, most of them are available in Spanish too. And there's a bunch of apps people can download. Some of these are self-help, like PTSD Coach or Mindfulness Coach. Some of these are treatment companions. So when I do prolonged exposure with someone, I have them download the app and they use it to record the sessions. They use it to complete their assignments, things like that. And Vet Change, anyone can sign up, even though, again, it's been kind of tested with veterans, but it's for people who want to cut down on drinking, who also have PTSD. So let me stop there, and I am happy to take some questions.
Please feel free to type your questions in the chat, or if you'd like to unmute and ask your question. I love all the resources that you've shared, Dr. Norman. I think those are really helpful. And I just want to remind people that we will be providing a toolkit for all the resources that Dr. Norman has discussed today, and probably more.
Yes, please use the resources. Please send us feedback, and please reach out with questions.
Well, while people are thinking of their questions, I want to just briefly, whoops, maybe not do that. Go through our end sort of pieces. I'm going to pop in the chat. If my technology will work for me here all of a sudden. I'm going to pop in the chat the link for the post evaluation. And again, we strongly encourage everyone to go ahead and complete that evaluation. Even if you only have time to do the first 5, that really helps our presenter know what you thought of the event, what you're getting out of it, etc. I'm gonna pause there. Kelly asks if a person is trained in EMDR, does getting trained in COPE make sense? Just trying to be mindful of the fact that training budgets are finite. So wondering about which EBPs should be prioritized when thinking about what to pursue.
Yeah, that's a great question. And we've done some trials to try to see, is one better than another? Is one better than another for like specific presentations or specific people? And we haven't really found that. So I would say if you're trained in EMDR and you it wouldn't be easy to be trained in another of the PTSD therapies. It would be great to use EMDR with these clients. If they're already getting substance use treatment, just do the EMDR. If you want to try an integrated protocol, there's no reason not to take kind of the substance use parts of COPE and integrate them with EMDR. That hasn't been studied explicitly, but I think that there's no reason not to. And I did just learn recently that a very big trial of EMDR for people with PTSD with substance use disorders was recently completed in Germany. So it's not published yet, but it sounds like they have good results. So I was happy to hear that.
And feel free to put your questions in the chat or unmute and ask. I've popped in the chat the post-evaluation link, as well as ways to get in touch with Great Lakes ROTA-RC. We'll make sure that Dr. Norman's contact and the center's contact is in the information that we send out post-session. Anticipate that the video slides and toolkit will be available within 48 hours. Try and get it done here before the holiday and make sure that everyone has access to all that great information. As well, we want to just share with you events that are upcoming here in July. I'm going to show you the website real quick. We have Preventing Substance Use Among Young Adults with Disabilities from former SAMHSA case manager Umberto Cavallo. And that is July 16th, so that'll be coming up here after the holiday. And then we have How Humor Helps, Applying Humor with Stress. This presentation from one of our presenters been with us before, Mallory DeSalle. She is being hosted by the University of Ohio Extension, and that will be on Thursday, July 31st. We also still have openings for the mental health first aid for military veterans and family. It is rural practitioners or rural areas. If you live or work in a rural area, we encourage and welcome you to apply for that session. Excellent. Well, if there are no further questions for Dr. Norman, I sincerely want to thank her for her time and for presenting to us today and to our community. We thank all of you for being present, and we hope to see you again here later in July for some of the great events coming up. If you need anything, need any resources, feel free to reach out. Otherwise, thanks and have a great weekend, everyone.
Thanks for having me.
All right. Thanks, Dr. Norman.